Actually, those who are on headed facility in charges forum, there is some link they have sent there. You can open and just tap on it. It will open and take you straight to the system. I'm just introducing this to you right now, but all health center 2s and 3s, you will get people to do a mentorship, to do a training for your staff. So on that day, please mobilize all the staffs, including those who are on leave and those who are off. Please, they come, they get them through the system. Otherwise, they will come back from leave. They work on patients. They don't have where to put them. So you're there. Username. You go to next slide, Kanonji. Hey, you're already there. Okay. Username. Put test facility 1. Small letters. Test T-E-S-T. Test facility 1. Test facility 1. Without space. Yeah. Yes. Small letters. Test facility 1. 1. Yes. A figure. Test facility 1. A figure. Test facility. Hey, okay. All small letters. Test facility 1. Password. Capital T. Test 1 at 1, 2, 3. Test at 1, 2, 3. Capital T. Test at 1, 2, 3. Test T-E-S-T. The username, they are all in small letters. Small letters. Username. Password, the T is capital. T is capital only. Test at 1, 2, 3. T-E-S-T at 1, 2, 3. Don't leave any space. Aha, good. It's going to come. There is no space anywhere. So as you're logging in, what we are going to go through right now is a demo. It's a demo, eh? But when we come to your facilities, we shall give you facility logins. The password is test at 1, 2, 3. Test with capital T. You're using capital letters.
Test is what?
Capital T. The first one is capital T. Others are in small letters. Eh?
1, 2, 3.
At 1, 2, 3. Username. And username is test facility 1. Small letters. No space. Are we all there? Because I want us. This one is there. Yes.
You say it is. Yes, T is capital. Yes, the thing is.
This is test facility 1. This is test at 1, 2, 3. These are small letters. This is the only one that is capital. Yes?
I think when you say art, we are like people write 8. So it's like the symbol of each.
The art is the symbol of each. Some people are Mitsela. Eh? No. Eh? Where are you? Not we have not. You are ahead of us. You are ahead of us. Others are still struggling to log in, to reach there. Who needs help? No, you see your password. It is test. You see the password is wrong. So the password is test.
Like this.
It is test at 1, 2, 3. Okay. I think we should go to next step. Please. Bring I write for you. Not. Yes, in charge. Let me write for you here. This is test facility 1. There is no space. This is capital test at 1, 2, 3. No, there is no space. Yes, in charge. Please, Mitsela, just come and help. Come and help the in charge here.
I'm already here, but when they ended, they told me correct username. Yes,
That's a username is test facility. Facility 1.
They told him that is correct. That's why I've gone back.
You put what I have given you now. This is test facility 1. Okay, let's go to the next step. Now, those who are exactly what they have projected there. That is the username and the password. So,
Are we progressing well? Because for me,
yes.
Hijacking when you are trying with things, I will hijack. I know this practical session now is
Just next 10 minutes.
Okay.
Next 10 minutes. I don't want to go into everything.
Because let people know what is coming ahead of us.
Yes.
I was going to the practicals now. People, we have not. Then we shall take a lot of time.
Okay. Are we proceeding well? Now, you go, scroll down the extreme end and register new client.
Without putting...
You go down and register new client. Click on register new client. So a patient will come, you will log in your username and password, you go straight to register client.
Then we go here.
Yes.
Then it is requesting this one is first.
Oh, okay. So when a patient comes, no, you had clicked on register client. You get it is up here. Register new client. So you have seen, I don't want people now because okay, I'm just introducing this to you. We are not going through the whole session because you will have, especially government facilities. Starting from next week, you will have people to come and train you from your sites. Government facilities starting from next week on Tuesday.
So I'm here.
No, then you put. So from there you go to, you put the national ID. You will be interacting with, if you have 90 OPD patients, you will have you. So the next thing, are we all together? It's because my phone has refused. I'm not moving with you. Let me just sit here.
What you do.
Okay. So, this is the next slide, after registering patient. So, when you click on register patient, that's what you receive on your phone. And where is the pointer? Those are the details of the patient you will put. What's the pointer?
We shall need to highlight with our presentation. This is a training.
Okay, let's just go through these slides. Then the process of registering a patient, you can actually take yourself. The system is very simple, but we shall go through it later. You can, we have people who can provide with you technical assistance. I am around, Mitsera is around. Then we also have Joseph. So let's just pay attention and go through these slides. There are few. So from after tapping on register new client, this is the interface you go to. It takes you to this page. You will be able to put the details of the patient. This is the section for the demographic information of a patient. You realize after reaching here, we have areas which are must fill. Like you cannot save a patient without sex or name or date of birth. Areas where you're seeing they have highlighted it in red, they are must fill. Then after filling these details, you register patient. Now from there, the patient you have registered will appear here. And from this section, you will be able to select a service type. You see here. So if you click on service type, the system will display for you the number of services that are offered in the health center 2s and health center 3s. Next. So you will be able to select from, if the person has come for outpatient services, you will select from type of services, you select outpatient, and the outpatient service will appear here. So you will be able to, for example, if someone has come for outpatient services, maybe TB and GBV, you select a number of them. You can select multiple, and all multiple services appear here. So from there, that's the next slide. Yes.
Know what we're expecting. I know we go for membership to the facility very soon, and otherwise, what
It take a long time.
Sure. Right.
No, I'm actually.
Let me just end the session here. Then when we go to facility, in the facilities.
We arrange a training for a specific training for this activity because we want to train beginners. And it is a very critical thing for our facilities. They need it. Mentorship would be better done at facility level, or we have health center, there is a health center tools come for this training specifically. Otherwise, we shall sleep here.
Okay. Okay. I'm stopping from here. Maybe now what I need to pass to you is starting from next week on Tuesday, we shall share a schedule how people will reach out to facilities to train you. Please, we shall communicate to you, mobilize your staff so that when someone comes, they find all staffs available. That is one. Two, we are going to share a spreadsheet, maybe via WhatsApp groups. We need number of computers, number of tablets, each health center 2, each health center 3 has, because it will guide on how many tablets will be brought to your facility. You get? I know people have, you have been asking how you're going to do this, whether you're going to use your phone, but ministry is going to support each facility with gadgets to use. But we want to first look at how many you have, then we will see how many we need to add you. Are we together? So the system is user friendly. You can the link I have shared with you is the demo link, is not a live link. Okay, so that is what I think I should stop there. Other things, the team will find you at your respective facilities and support you. Thank you so much.
Thank you for that presentation. We are not going to discuss it. We have agreed. We are going to have the teams come to facilities to train. I have called on Karami to come and present first. Karami is around. We are giving you 5 minutes. We are giving you 5 minutes to present. Meanwhile, where hospital, prepare, you are the next. And after where Kagano hospital will follow. After Kagano shall have Kagame. So those people, please help us. If Garam is not ready, then we can go on the next person so that they prepare themselves as we. Yes, all those with presentations, make them ready so that immediately the other one goes off, then the other one comes on.
Actually, let them bring the presentation to Murele.
Yes, whoever has a presentation, come and submit it to Murele so that we have one computer, they should be able to slide it here. Here we call you on. Because it is going to take us long for us to keep preparing for presentations. So where Kagame Hospital, Nyagarame, then we have the Rukoki, I think their presentation is still having issues. Nyagaroko Health Center 4.
And if they are not very ready, we can start on partners. They seem to be ready. Partners are ready.
Let's begin on.
The partners are ready.
Yes.
Yeah. Now let's call on partner, starting with the medicines. Please come on board. Thank you. Provide for them the microphone.
Thank you, Chair, for giving us the opportunity. All right, thank you, Chair, for giving us the opportunity. And all protocols duly observed. Is that it? And good afternoon, colleagues.
Good afternoon.
I am Sonny Israel. I'm the project coordinator for medicines in Kasese. As you already know, Medicine is an emergency organization. We have been in Uganda for over 40 years. And in these 40 years, we've been involved in different kinds of intervention, including emergencies like viral hemorrhagic fever, cholera, civil strife, including HIV. In fact, we were in Arua collaborating with the Ministry of Health to do HIV program for over 25 years. We exited Arua in 2024. Please, next slide, please. So here in Kasese, our medical activities includes adolescent services. And this is divided into two groups. Now, the reason why we went into adolescent services or adolescent care is because the adolescents are a vulnerable group, and more especially the females. So we have the general outpatient services, which the inclusion criteria is age 10 to 19 years. And we have sexual and reproductive health, which includes antenatal care, postnatal care, gender-based violence, family planning, and EPI. We also have mental health and psychosocial support. I will come to that, the reason why that is very important. I recall yesterday, the cow was saying, why is it that mental health is not much mentioned in our activities at Ministry of Health? Now, we also have the health promotion and community engagement, where we have a resource center and a recreation center. And of course, we have laboratory services. Now, in sickle cell disease, the inclusion criteria is 9 months to 19 years. Now, you recall that there's a report from the World Health Organization that says that Uganda is the fifth country in sub-Saharan Africa with the burden of sickle cell disease. And that 20 to 500 children are born in a year with sickle cell disease traits. And that about 80% of them will die before their 5th birthday if they do not have access to appropriate care. And that is why that informed us why we also included sickle cell disease. Now, the approach to sickle cell disease is parallel in that at CAC, KMC, we have the outpatient department there, and we are, as collaborators of government, of our Ministry of Health, we also have satellite, centers in Health Center 3 at Hima and Health Center 4 in Nyabirongo, where we are also, doing the services. So at Kasese Adolescent Center is MSF pure activity. And we also have referral services because we are an OPD, and all the adolescents and all the patients that come to us, when we do not have an IPD, an inpatient department, so we refer these patients to several hospitals. In fact, our primary hospital of referral, especially for reproductive health, is Rukoki. And then we can go as far as St. Paul and St. Mary's. All these services are free of charge. Now, our performance indicators in 2025, in general OPD, we did 2,100 consultations. We enrolled 666 sickle cell disease warriors, and among this enrollment, 538 of them are active in our cohort currently. Our ANC consultations, we did up to 8,000 ANC consultations, and PNC dropped to 810. Just like I was looking at the statistics of the Ministry of Health, PNC is always dropping. It's not going up. Now, our contraception, we had above 1,000 contraceptions that we administered. Sexual violence, we recorded 97 cases. Of course, we normally, when we have cases of sexual violence, we normally liaise after the initial treatment. We normally liaise with the probation officer for further management. And like I said, our referrals toward up to 1,400 referrals. And these referrals are cases like complications, especially complications resulting from sickle cell disease crisis. And we refer as far as Mbarara Hospital, and of course in Fort Portal. Now, all these referrals, MSF is responsible for the referrals. And for adolescents with complicated deliveries, we refer to Rukoki. As you know, Rukoki is an extremely busy hospital. And I really praise the people, commend the people who are working there, because in Rukoki, if there are 20 bed spaces for admission, if you go there, you have 40 or 50 admitted patients, a space that is meant for 20 beds. Now, if you look at the achievement that we had last year, the general OPD consultations was up to 32,000. That includes the general OPD and emergency consultations. And then you go to sickle cell disease, we had up to about 1,000, above 1,900 consultations. And like I said before, 538 are active cohort, whereas 225 are active on hydroxyurea. Now, last year in August, September, we introduced hydroxyurea into the treatment of sickle cell disease. And in every month, we were referring not less than 3 patients to Mbarara Hospital and Fort Portal. By January, they were asking us, why are you not referring patients to us? And we discovered that because we place these patients on hydroxyurea, the crisis rate, the complication rate has actually diminished. And I can tell you, in the last 3 months, we have not referred any patient out because of crisis. Now, for ANC, our consultations, like I said before, is above 8,000. And of course, family planning and referrals to secondary care, above 8,400. And of course, maternal referrals. This is very important. And that is why we are into the adolescent care. Because most adolescents who are pregnant, usually the delivery comes with a lot of complications because they are vulnerable. And I can tell you that most of the adolescents that we refer, they end up with cesarean section. Only few deliver normally. And so when Rukoki is overwhelmed and we refer to St. Paul, we refer to St. Mary's, MSF is responsible for all the payments. And of course, when we see patients in OPD that falls within our inclusion criteria, these patients, be it fracture, be it medical, be it surgical patients, when we refer them, we are responsible for all to cover the payment. And you can see how many of them that we referred last year. And this is very important, to mention that a lot of the private hospitals around have actually benefited from these referrals. But the most important thing is for us to enable to see that these vulnerable groups are taken care of. Next slide. And then we also, into improving the infrastructure of these MOH facilities that we collaborate with. Now, in Rukoki, we were the ones, to start with. We built the maternity ward and the operating theater. But last year, early last year, we did a renovation of these two units. And of course, we installed and we keep maintaining the solar power that is in the operating theater. In fact, the last maintenance that we did for the solar system was in December, January. Of course, the waste zone in Rukoki, we were the ones that constructed it, and we did carry out a renovation maintenance in October last year. And of course, you recall that last year in about September or so, where the big tent, the rub hall that used to house the male and female wards, the patients were admitted there when the wind and storm came and blew inside. And so currently, we have removed that old skin and we are replacing with a new skin so that whatever activity that is going on there can be safe. So in KMC, if you have not been to KMC in the last maybe 1 month and you go to KMC, you will see that there's a whole lot of infrastructural development that is going on there. And MSF is responsible for that. The construction of the ramp at the triage is ongoing, and then the painting of all the departments of the facility is ongoing so that we can improve the infection prevention capacity over there. Now, we also provided a solar power that is being connected to the lab, the administrative building, and the maternity building. We are also carrying out an upgrade of the water works, so we are re-engineering it. Now, currently, the water tanks, the water volume capacity there is about 10,000 liters, but we are upgrading it to 25,000 liters. And most of the pipes that are connected there are old and rusty, and so do not supply the water network adequately. So we are also excavating that and ensuring that there is enough water capacity and the network is true. And currently, we have provided 20 new beds for admission in the maternity ward and mattresses. In fact, KMC is looking for where to store the old ones now in order to replace them with these new ones. Thank you, Chair. Now, before I go further, there's something that I really want to appeal to government here. And the appeal is that Kasese is one of the top 3 districts in Uganda that has the highest rate of adolescent pregnancies. And the reason why I'm doing this appeal is because on a monthly basis, we have at least not less than 150 new adolescents who are coming to register for ANC. And that figure is not good for us. And the reason why I'm appealing to government now is because there are some districts that have enacted enabling laws to be able to curb teenage pregnancies. One of them is Ginger, and there's another one in the north. I've forgotten now.
It's for next slide.
Okay. So I've forgotten the other one. Now, if in this district, if you're an adult and you think you've caught a new meat and you go to the hotel and an adolescent is entering that hotel, don't just be happy because you're in a trap. There are people who are positioned to track adolescents who are going into hotels. And just when you think you have closed the door and you're about to enjoy, you will hear a very dangerous knock. And before you know what is happening, you are dragged out. And then the next place you find yourself is police. And if you're not careful, they will pound you very well before you get to the police. And so those places have been able to curb adolescent pregnancy to a very large extent. And I really appreciate if in our own district, if that can happen. Because we see situations where some organizations in the daytime, they are canvassing against adolescent pregnancies. In the night, they are doing carnivals that, if you see these adolescents, the way they are dressed, I don't know. So the rest you can complete it. So I will really appreciate if the authorities could give us, enact enabling laws to curb adolescent pregnancies. Okay. Now, for KMC and CAC specifically, because within the compound of KMC, there's a lot of construction that is going on there. And so we are expanding the observation room and the patient waiting hall. And there's also a new block construction for ANC, PNC, and EPI. Of course, we are constructing a laboratory in order to be able to run comprehensive investigations for sickle cell disease. Previously, we have been outsourcing these investigations. And in every month, it was costing us not less than 15 million to carry out these investigations. Because for you to place these patients on hydroxyurea, there are basic investigations that they need to go through as you titrate the drug upward. So by the time we finish this construction, we will have all our comprehensive investigations inside of CAC. Of course, we're also constructing a staff meeting room. Now, in HIMA, because HIMA is one of the satellite health centers where we are doing the consultations for sickle cell disease, it's actually integrated. The reason why MSF is into all these activities is to integrate and build capacity of the Ministry of Health staff. And so in HIMA, we have modified the bench in the lab. So the old bench is there. We have modified it and put concrete and fixed slabs. We have fixed wall tiles above, these benches. In fact, there was just one bench. Now we have made it 2 benches. And we constructed extra concrete bench. We have replaced the stainless sink with fiberglass laboratory sink with a complete drainage accessories. We have created an additional sink for the laboratory, for the technicians to be able to wash their hands and work freely. Of course, we have repainted the walls and fixed a notice board. And even the leaking roof in the waiting area, we have fixed it. Now, in Nyabirongo, we plan, because Nyabirongo is one of the health centers that has been upgraded to Health Center 4. And it's the same thing that is happening in Rukoke, because the volume of services have increased. And the infrastructure and the human resources have not also commensurately increased. So our plan is to create 2 additional consultation rooms in the ANC building. And we also want to expand the waiting areas to 2 because there's a lot of congestion and there's no space for them. We plan to renovate the laboratory as well. However, when we wanted to do this, we realized that the building has a lot of cracks and damages. And we were not sure if we do this, if the building was going to hold all this renovation that we want to do. So we hired a consultant to do a feasibility study. And we'll be having the feasibility study of the buildings anytime soon. Now, we have some challenges. And what are these challenges? We collaborate with the Ministry of Health to build staff capacity for the purpose of integration. At CAC right now, where we are, MSF is not going to be there forever. And by the day MSF leaves, we are handing that over to the Ministry of Health. And so we expect that the Ministry of Health should be able to take over, these activities without stress. So, lack of human resources for capacity building is a big issue. Now, in our contract, we had about 7-8 staff seconded to us, but right now we have only 3 staff. And if MSF leaves today, we don't have that capacity. That capacity will not be there to continue the activity. So we are appealing to the Ministry of Health and Government to ensure that the presence of MSF here is utilized even after MSF is gone. And the trained staff are not, stable in the facilities. some of the facilities when we go, we train staff. And after a while, you go back, you don't find those staff anymore. They're no longer there. And so MSF end up doing consultations ourselves. And this is not good for the collaboration, because the essence, don't forget that what is going on with sickle cell disease today is not good, because these children, the people in the communities think that the etiology of sickle cell disease is either witchcraft or it is contagious, which means if a child goes to play in the neighbor's house and the child has sickle cell disease, it means that child will transmit sickle cell disease to the children of that family. And this is the mindset of people. And so once a child has sickle cell disease and is diagnosed, the family of the husband will begin to say the wife is the cause of this sickle cell disease. And before you know what has happened, it's a broken home. Okay, the wife goes away, the husband goes away. And then the child is sent to the grandmother. And I don't know how it happens. In most of the cases that we've seen with broken homes, as soon as they break up, there's a man waiting to carry the woman and put in his house. I don't know how that happens. But in most of the broken homes that we have seen, before you know what is happening, as soon as this woman leaves, another woman is coming in. Now, that child is left in a dilemma. The day the child goes to visit the mother, they chase the husband, people chase him away. Don't bring your sickle cell here. The day the child wants to go and visit the father, the new wife says, no, no, no. You cannot come here because you're bringing a sickle cell here in this family again. The child ends up with psychosocial trauma. And that is why we have, the psychosocial counselors who takes care of these children. And us, of course, we have the social workers who assess the child, their social needs. And as much as our resources can take, we try to support these children. So if we train staff and the staff leave and the knowledge is not resident there, then there will be knowledge deficit. As a result, the patients will not gain from it. Next slide. Now, this year, we have these prospects to continue to strengthen the care, and the components at CAC, at the Adolescent Center. We'll continue the medical management of sickle cell disease with a strategy of decentralization and the one at CAC. Of course, we create community awareness because we have the health promotion team that goes around schools, goes around churches, goes around public gatherings, go to different places to do different forms of health promotion activities. And of course, on a monthly basis, we are on air on the different radio stations to also do health promotion over there. The upgrade of the laboratory to include hematology, biochemistry, and electrolytes. This is very important for the improvement of care of the sickle cell disease patients. Of course, we are looking at a situation where we develop a research collaboration with the Ministry of Health and our division that is responsible for laboratory research at Mbarara Regional Hospital to be able to do a scientific knowledge about sickle cell disease and the use of hydroxyurea in order to be able to cascade the treatment around, other health facilities and outside of Kasese, and to extrapolate it further outside of Uganda. So that we are looking at it. In fact, recently we had meetings, and very soon we'll be applying for the ethical review board. And then respond to collaboration with the Ministry of Health in humanitarian emergency. As you know, MSF is an emergency organization, and we are positioned here in Kasese. Should there be any emergencies? Is it viral hemorrhagic fever? Is it flash floods? Whatever that is an emergency, we are ready to collaborate with the Ministry of Health to respond. So that is what we achieved last year, and this is what we intend to achieve this year. Thank you.
Thank you so much. I think we get the second presentation from together so that we can react to us. I will request that you become a bit faster. Meanwhile, as he comes, I want to recognize the presence of the control team, which is headed by the community department. Head, Dr. Iyita, please, wherever you are, please, the chief can stand up for recognition to the members. Thank you. You're most welcome.
Okay, thank you, Chair. As Taylor, we remain committed to improving service delivery, and the service delivery outputs that we consider are the ones that the facilities present, the ones that are in the national system. I am called Peter Ayewatiwe. I work with Taylor, and I'm in data sciences, supporting Kasese last time. But our interest still is biased a bit with HIV, TB, non-communicable diseases, and the local security, where we support around 25 facilities. We all know about the reduction in funding for the US-based funders, and that leads to a change in the implementation model. Right now, we are going to include the technical assistance model, where the districts take lead, and the strategy is actually sub-granting, sub-granted almost all the entities in the health sector, right now from the DHT, municipality, and the 24, around 23 health facilities. We remain in the background to track the accountabilities from your end and the results as well. Other achievements usually come in based on need. For example, in Rukoki, in the digitization agenda recently, supplied hospital with around 10 computers. Recently, Wera, we supplied around 3 computers. And a number of you have received sanctions for your laboratories. So the support keeps on based on need, and we remain committed to serve this district for the betterment of health services. Thank you very much.
Thank you. I think I call on the Population Services International. They are there. Come and give us a brief, like Baylor has done. Thank you.
Thank you so much, the moderator. And good afternoon, ladies and gentlemen. Bamwesige Ezra is my name, and I happen to be the coordinator, PSI Uganda. And I take the opportunity also to welcome the DHO I worked with once. Windiwujo, you're welcome. PSI Uganda is a global or international organization based in Kampala, and of course, our head office is in Washington. In Uganda here, we have been here for over 20 years, assisting Ministry of Health to achieve their mandate in health system strengthening and service accessibility, especially sexual reproductive health. In Kasese here, we have been here for over 10 years now, though we got a break in those days of stop work order, which kind of affected us. I think we sustained up to November, But the good news is that we have transitioned that project into our sister organization called PACE Uganda. I'm sure most of you have ever worked with it. And PACE Uganda will be resuming those activities in March. Purposely here in Kasese as PACE Uganda, we have gotten a grant from UK. And this grant is going to implement a project under the adolescent health. And especially we are starting with the 5 sub-counties which are prone to climate disasters. This project is intending to assist the adolescents to freely access health services. And one of the things that we are doing both community and facility level to ensure, as you're aware, Kasese was ranked number 3 teenage pregnancies. And these teenage pregnancies, this project is looking at how to address and put its contribution in reducing teenage pregnancies, but also improving livelihoods of those that are victims. We all know that after the pregnancy, these girls are abandoned by the perpetuators and also abandoned by their parents somehow. And so this project is looking at taking them through that journey of pregnancy and delivery, and then also to stop the next pregnancy. If you keep quiet, they end up with another teenage pregnancy before they are 20. So in that, we want to also address their livelihood to ensure that after birth, they can get skills and also take care of their children. One of the major projects under this will be the construction of the maternity shelter. We are already in discussions with the district, and once we identify a facility, which to us and to the community which we investigated from, they have highlighted in Nyabirongo Health Center 4. Once we finish those, then this year we should see construction coming up, and it will be a construction that can actually capacitate about 70 AGYWs in that maternity shelter. So for now, the facilities, the sub-counties we shall be working with, we are already in progress, coming for baseline assessment. Some of them we conducted them yesterday, and we are continuing to finish. Once those assessments are done, then we expect activities to kickstart as early as March. Thank you so much for now. And maybe to say that, maybe for the congregation to know, we are not covering the whole district. For now, we want to start with the 5 sub-counties that are prone to disaster. That is Charumba, Monkunyu, Mahango, and Kirembe. And then after that, we shall do an expansion following that.
Thank you.
Thank you so much. I wish you the best.
Let's have Acts Uganda. Let's have Acts Uganda. They are everywhere. It's very fast. I kindly try to utilize around 2 to 3 minutes because we are time back. Thank you.
Good afternoon, everyone. Yeah, this is Martin from Acts Uganda, representing the project director or the programs director. So, as Acts Uganda, it is a WASH-based organization that has been working in Kasese for almost 2 years of recent. It has ever worked there way back in 2010, which was Buisum Parish. And that's where we are based, unsafe water for domestic use, We look at poor sanitation and hygiene practices, then the inadequate income to facilitate household needs. So these are the program targets we had for 2025 in Kasese district, majorly Kasangari parish. We looked at the shift of transiting communities to assess basic sustainable wash behavior change, reflecting improvement not only in infrastructure, but also in hygiene culture, environment sanitation, and household dignity. So what we have done, continue, on the part of infrastructure development, we have constructed a water source point and protected it for the people of Kasangari, constructed a reservoir tank of 40,000 cubic liters of water, which is serving over 20,000 people in the Kasangari parish. 56 tap stands with a health center, that is Kasangari Health Center 2, and school have been provided with tap stands and they are functioning. So we have built 3 latrines for girls at schools to enable them during their menstruation period and access to privacy and safety for the girl child. Sanitation and hygiene impact is based on these households. They have been empowered, trained, and they have known the importance why they should have a latrine. And during the last year, 6 villages were certified ODF, which means open defecation free villages. We have ensured gender equality through increased school attendance in class at 1%. That's why we see the 3 latrines that we have built. Then we have the performance indicators, where we have the poverty reduction. Our current target is 30.4% poverty reduction, but our target was 40. So water access within 500 meters for all people in Kasangari is at 100%. Our expectation was 99%. Then waterborne disease occurrence reduction, we had, as of now, we have 69.4%, as our target was 60%. So we have met our target. Primary school increase on attendance, 50%, that's our current target, and we expected to have a target of 60%. Household income increase through life gardening and entrepreneurship. Okay. I can continue from here. We have 60% of the current target and we expect 90%. So our key challenges during the implementation was, after this implementation, after training, enabling these communities, they tend to go back, or what we call the ODF slippage. So that's why we ask the implementing partners, the district, at the local areas and whatnot, to look at how they can prevent this ODF slippage. Then we looked at the vandalization of water points and pipes, because when you are implementing a certain project and people keep on cutting pipes, cutting on the water taps, that becomes a challenge, not to us, but to the community. So we request the district to do more mobilization to why these things are there and why they should embrace them. So lack of coordination, that's a challenge for us to face, and you as we are here as the district. So ongoing projects as of 2026, we have a retrofit or renovation of the Bisumbu Parish water sources and the Kabatunda Town Council. So we have the sanitation and hygiene promotion that is ongoing. Thank you for listening.
Thank you so much. presentation. Let's have a statement from Stanley as we welcome Dr. Grace from the gate of Bujo. Stanley, we shall give you like 2 minutes because we had you present yesterday. We have brought you back on board. Kindly summarize because we are very bad. Thank you.
Thank you, moderator. Good afternoon, everyone. Okay, I'll also introduce myself. My name is Ivan Ahabwe. I support personal banking at Stanbic Bank, and in that regard, I support this region. So, Stanbic Bank, we've also become a good partner with the Ministry of Health that directly supervises the health units that you work with. So we are not here just for business, but as strong partners with the Ministry of Health. So we've been working with Ministry of Health now for a long period of time, supporting different referral hospitals, and also health centers. So for this district in particular, last year we supported you at Lukoki Health Center 4, now hospital, with medical equipments and other assorted items with over 80 million Uganda shillings. So as you can see, that is not something small for a business organization or institution. So now what brings us here today is also to continue requesting you that in case we reach out to you where we need to support you, please provide us with the necessary information so that we continue partnering in that way. Then in terms of how we are also supporting you as individuals or businesses, we have products that we have as a bank that we've put in place, or that we have in place, that will continue supporting you. We have affordable salary accounts. Some of I know most of you earn a salary at the end of the month. Then unsecured and non-guaranteed salary loans that we currently offer you at 17% per annum. So please look out to that. We also do financial advisory services through our financial fitness academies. We also do that at no cost. So if you are at a health center or at a hospital and you organize yourselves as staff, we can come through, then we take you through financial fitness training at free of charge. Then another most important thing that we are running with this year is our digital platforms. USSD star 290 hash, then our internet banking, Stanbic app. We are putting all these in place to ensure that number one, you have convenience. We know this district is still very big, so people traveling long distances to come to the bank to transact, that's not nice. So we want you to transact at the comfort of your workplaces, at the comfort of your homes. So we are again here, like I mentioned yesterday, our teams are outside there. We have a desk. So reach out to us, ask any question. We'll be able to get back to you and support you. We thank you. For those maybe who will also need to contact me directly, my number is 0783 382638. That is also on WhatsApp. Thank you. 07, people have requested me that I repeat the number. 0783 3826 and my email is ahabwei@stanbic.com. Thank you so much.
Thank you so much for the presentation. I believe members will come and see you as I welcome Dr. Chris on. Allow me to recognize the presence of Principal Assistant Chief Administrative Officer. You're most welcome. Thank you for joining us. We met when we were at the crash hour. We are trying to catch up with the program. So, Dr. Chris, our DHO Bulbujo, please, the floor is yours. I'll give you like 5 minutes. In 5 minutes, you'll be done with the presentation. Thank you.
All protocol observed. Good afternoon.
Good afternoon.
I'm into public health and I may not continue after realizing that we have sat for 2 hours, and I will request us to stand up, stretch a bit for your own good. So, okay, thank you. So we can have our seats. Ideally, it's not advisable to sit for more than 2 hours, and that's why my seat keeps on lowering. The seat with my executive seat keeps on lowering, and I have to keep on standing to adjust it. That's how I keep exercising within the office. As I'm Christopher Chita, I'm in the capacity of the head of department, public health for Porto Regional Referral Hospital, and I'm glad that Dr. Amon is your DHO. I was his medical superintendent in 2014, and I handed over to him. So now he's my colleague. Congratulations. So the world is round. So we are the same rank. The men and the men we are. Now Fort Porto, I'm not to go. We know our hospital. We had a meeting with the district of government, and I know some of the things we have discussed are pertinent to and also feed into this response. I need to appreciate the Kasese district of government for working closely with the Fort Porto Regional Hospital, and I bring to you greetings from the senior executive consultant, Dr. Aziz Ashbout. He was not able to be with us as a critical meetings attending, but he is with. I shall give him the report. We identified that mental health issues are not fully integrated. I'm told the DHO has told me that you have moved on. Unregistered churches that do that ID clients. I don't know how, and we thought that is this something which is which can disturb the peace of the department. Then uncoded ambulance system, he has told me you are aligning it to what we call the Kamuri model, because that's what we discussed, and we are grateful for that. Then the vaccine coverage is we are at a risk of measles outbreak because of the proximity to Congo and the other uncovered areas. So I expect also this one as we move to may be addressed. We also we looked at funding. As I'm glad for we still have partners. Some districts they don't have more than 2. So we look at that and we say that we continue to lob for funds. Now there is this one number 6 of concern, and that's one of the reasons why we are coming down to districts is the congestion brought about non-functionality of our facilities. Now when these health center falls and general hospitals are congested and they have issues, they are blamed. Yet the issues arising at those facilities are consequences of non-functionality of health center fees. And the same was happening with the regional referral hospital. So we want also to see that districts are doing their work so that the regional referral hospital concentrates on specialized services. So I don't know how we need to address that, because you find that maybe a center which has never even admitted more than 100 patients since it was established. Number 7 was the support supervision. And here we are putting also the HSDs, because the idea the DHO is supposed to stop at general hospitals and F center first, and then HSDs take over. So we have a gap here, and which we agree that it needs to be worked on. Low performance community interventions. Yeah, it's told me they are handling, and the absenteeism and non-performing staff. This one, ideally, if it is worked on, we shall have moved in this, because it's pains that for you work all days and your colleague works for half of the days or 25% of the days, and you are getting the same pay. Okay. For us in my system, if I find that you are not working and you are being dodging, I add up your days. If you don't reach somewhere, I don't pay, and I don't pay an area if you have missed it because of non-performance. So we need to move, and I realize that if you don't pay somebody salary for absenteeism, they run a route and they will never do it. But if you keep on, because it's by policy that if somebody has not worked for 5 days, more than 5 days, you don't pay. If he has worked in not more than 12 days, you pay 50%. It's there. It's written by public service. Okay. So now we need to move from just talking to action. For me, you don't. I find out you don't, and even if you request for what, and even if you do what, it's the order decide that you are not going to get that pay, and that's the standard. Okay. Now then non-performing staff. There are those people who appear on the facility, but there's no work done. Okay, they are even in some of them they are playing Rudo. Now this maternal and perinatal death not notified. He has just given me that your perinatal deaths are even increasing than decreasing. So we expect a deduction from 20 something, which you had last year, but I'm told now you are in 30. Now the 2 quarters. Now what I request, one of the things which I did to manage perinatal deaths is to identify who are involved. That is, I isolate those people who are involved. There is some similar characteristics, and some of them I found out that they don't have skills, and we are touched, and the thing is improved. So we need to go deep and have it as a QI project, which you need to improve. I know those things can happen. It means that we cannot be sterile, but they can be prevented. So these are some of the things. In the interest of time, I'm told you are going for lunch. Let me present this. The last thing will come maybe after. It is about standards, but not now. It's about standards, what we expect you to do, and it's going to be helpful to you as a facility in charge and as a DHT. So I say all this for God and my country.
Okay. If the chair is out, I don't know what is on schedule. Any other partner who is another partner that can summarize the next 5 minutes? Because it seems we need to go for lunch right now. If there is a partner who's there, please let us take you on. It seems to me like those are the partners we have. We are sorry we've actually gone beyond our time. I want to thank my mentor who comes from the Regional Referral Hospital for that presentation. It was very precise and brief. They gave you 5 minutes, I think we did just about 2 minutes. And he really spoke to all that we have been speaking here. I don't know how we just learned of whatever we spoke and we just went directly to those. So it seems we are going for a lunch. Please take note of whatever has been presented here. We are not going to waste more time. We want to go for a lunch. Let us take our lunch very quickly. We have the next few minutes to go for a lunch. We come back and respond to some of the issues here as we go into near the last sessions. In the last sessions, as we said, we might have a few facilities making brief presentations, but also we shall now go into the breakaway session, group discussions, and we have guided questions here. When you reach here, you will respond to these questions in groups. Then when you return, we shall make action points out of those things we will raise from the groups there. The questions are here already with us.
So we beg that we go for a lunch right now and we come in time to come and make some conclusive issues, some issues, rather some things to finish up with. So we shall give out these questions when we return. Let us go for a lunch. We request you to raise up for prayer and we can go enjoy our lunches. We raise for prayer and we go for lunch. We are praying. Lord, we want to thank you for this time you've given us. We are grateful that we've been here the whole day since the given. And we are grateful though that we've really been breathing your free energy and breath of life. We pray that as going for a lunch, take us through and lead us back here safely after lunch as we progress into the next sessions. We pray this and request that as the food is placed before us, bless it, our nourishment. In Jesus' name we pray. Okay.
lots of people trekking from the side of Wera coming to Kasese. So we are trying to ponder on whether we may not have an opportunity to view extending the other side so that we also target the numbers of people who don't afford to come and meet you where you are. Think about it. It will be of great importance for you to widen your scope to the other area so that we target large numbers. I want to thank you for that. Once again, members, I want to welcome you to the land session. And those who are still outside, we call upon you to come and enter. And those who are inside, I want us to give a round of applause to the presenters who have so far presented. They have been presenting when we are not clapping for them. It was intentional because I looked at the time and I have reserved that. When we come back, we shall give them a round of applause together. So let's clap for them. And we appreciate them for having presented. Going forward, I want to welcome some questions about the presentations, and if they are not there, then I will pass the mic to the next session chair, because my time is expiring. This morning I've been cruising, so I want to also retire. You know, for us in our side, which Kao doesn't know about, for us retiring is part of us. Chairman is here representing that side, but for us, our side, retiring, we have term limits. If you don't retire by the 2 terms, for us to retire you. That's what we do. So I also want to retire immediately after the questions. I am only having one arm. If there is another, I want to pick around 3 to 4 so that we start in order. Okay. So I have one. I have the DHO. And I think they are only those we have to allow. So take on the mic. It becomes very brief because we are time bad.
Thank you very much, Chair. Right away, I want to thank you. And through you, I want to thank the staff. I was given us a very, I would like to attention because everybody was seeing it. Thank you very much, MSF. MSF started coming here in Kasese many years ago. I think it was 2013. And before that, when we had the cholera. And there was a certain European who came here and wanted to look for people who had experience in these areas of health. And I was mentioned somewhere in Kampala. So when the cross, I remained very much. I'm not that detail because I know what I'm saying. I remained. I was the first one to take it up in the Mahamud area. It was a different place. I want to thank you, sir. In addition to thanking you, the construction, all the what was given here, I think it was lively, and that I want to sincerely thank you. Not all civil society organizations do the work of development. You have a short time, but for you have got back. I want to thank you. In the areas where you are operating, I was the first chairman unit. The land you are operating from, I saved it very from the disorganizers who wanted to eat it there. So when I go there, the trees you see there, I want to thank you, the government, sir. On that, I will make some little requests. I know we are now caring for the children from 10, is it 9 or 19? I don't know in the future whether we can also start from 5 and we reduce it from 19 to 17. So that those ones who are also vulnerable there can have it because you have the best. sometimes we can get out of stock. And we said that it will have to us. So the building, I was there 2 days ago. I was very happy what you are doing. But we had also constructed where you are also next there. So if resources allows, you could extend that one and renovate it, because that's why we talk about food hygiene.
Colleagues, let's pay attention.
I think that these people, I'm just talking for you people now. So if that one can be requested, accepted the song, it is very, very good. Having the uniform of cleanliness and others, there are very many things. Then it was PCI. I want to thank you, sir, PCI. You said you were in Uganda 20 years, but in the Kasese here, I started recognizing you when you had a nasty dust in Kirembe, while the nurses' home had been swept out. Our friend came there with the kitchen kits, and they were trying to find out who could really take care of those back sacks. And again, there was one of the people asking, who can do the work of voluntary without any whatever? And I want to thank you, sir, PCI. I've heard you talking about wash. I think it would be very good that we really will have that program in the other areas. I remember when we started treating cholera here, people thought it was a viral. And they were saying, no, this was just oral. It was not, and we started now, even having this, because people understand that disease. And we started to go to all the areas in Hocha, Sandara, and other areas, when you people were still even younger, some of you were still in school. And that's how we started saving the people with the cholera. I will not go into it because that's what you are treating. So,
thank you so much.
That's the minute.
Thank you so much.
Okay. Thank you very much, sir. With appreciating all those friends forward.
Yes, we are time bad. Thank you, Doctor, and representing GoBR. We are grateful. DHO, please, you have an answer to a question we asked. Colleagues, can we become attentive so that we finish early?
And I think mine was just the response to what you said. And I'm like trying to answer for MSF. MSF already showed us what they are doing in regard to sickle cell care. Their center is at CAC, but they have had satellite centers. One is in Nyav. Ask whether they can have an extension to other areas. And our suggestion was we also go to the west and also to the further north. So a month ago, their team and ours went to your site to try to find their interest in more of the health center 3s and 4s. We assumed that the hospital already has a very organized sickle cell clinic. That was the assumption. So we first ran to Karambe for an assessment. So we have assessed 2 other areas, that is Karambe and another one on the other side. So the evaluation findings are not yet out. When they evaluate and they really see that that side has numbers which are coming right away from that side to Kasese, you will be served, sir. So just keep waiting.
Thank you so much, Doctor.
Thank you.
I think it has given us the answer, and I want to presume that we no longer have any other question in regard to the presentations made prior. Proceed to pass on the session to the next chair. But before I pass the session to the next chair, few comments to pass. The first one is an appreciation to Ministry of Health for a quick response. When Dr. Diana Twine came to Bwera, she noticed a lot of challenges and she has been able to swiftly respond. We have received the equipment she promised in the immediate. Incubators have reached there, drip stands have reached there. We are receiving suction machines. We have received some concentrators, and yesterday, but one, we submitted for the remaining equipment. So the answers have been given. If you reach there, please send our appreciation. Then the other issue, I have had the partners invested in TB. I want to call upon the partners that in Bwera, the situation is too bad. I want to use the word too bad because we are admitting the TB patients in a ward where we are having the normal patients, and it is a normal, it is found normal. We brought this to the attention of the district, the DHO's office, and Dr. Diana Twine herself witnessed it. So we are still escalating it to the partners that in the meantime we can be rescued. Even if it is a tent, it would be of great value. I want to thank you if you help us in doing that. Then the next issue is I want to thank you for being a good audience. This morning you've tried to give me attention as a session chair. Thank you so much for being good listeners. And I want to thank the organizers for giving me an opportunity to chair this session. And I want to hand it over. Thank you so much. Thank you, and thank you once again. Clarence Wambale is my name, the Senior Hospital Administrator, Wera Hospital. Thank you.
Thank you very much, Senior Hospital Administrator. Good afternoon, members. I want you to appreciate the previous chair in my proposal. We shall have a clap. It will move like this. Because of that, because of that, most importantly, that is for you. I want to thank you for the time you have dedicated to this important performance review meeting in the health sector. Having time and you sit down, you review your plan, and you make an action plan for the next quarter is very, very important. Now, we have been listening to very many presentations. We are going to have 5 groups. And we are going to group ourselves into 5 groups. Each group is going to have a task to generate views, points, and after you will present to us, then make an action plan from what you will present. All of us now we shall discuss and agree. I want to ask the Secretariat to come and help. We are going to have 5 groups. And group 1 is going to handle human resources for health. Human resources for health. That is group 1. Issues to look at: how do staffing levels and staff distribution affect service delivery outcomes in Kasese district. Another area is what strategies can be adopted to improve staff retention, motivation, and performance, especially in the hard-to-reach facilities. That is group 1. Then we shall have group 2, accountability for medicines and supplies. What are the issues we shall look at? What systems, weaknesses contribute to stock out and expiries of essential medicines in health facilities? Area 2, how can accountability be improved across ordering, storage, and dispensing of medicines? Area 3, what role should facility in charges and district managers play in ensuring transparent medicines management? That is group 2. Group 3, integration of HIV services in routine care. What are you going to look at? To what extent are HIV services fully integrated into routine outpatient, maternal, and child health services? 2. What barriers prevent effective integration of HIV testing, treatment, and follow-ups into routine care? 3. How can integration of HIV services improve patient outcomes and reduce stigma? Group 4, health facility reporting rates. There are also 3 areas. What factors explain gaps in reporting timelines and completeness among health facilities? Area 2, how can data qualify and use of routine data be improved at facility and district levels? Area 3, what accountability measures can encourage better reporting performance? Group 5, environmental health performance. This is where we have to look at, because it is a preventive measure. Environmental health issues. Area 1, why do latrine coverage and hand washing facilities indicators remain low despite ongoing interventions? Area 2, how can multi-sectoral collaboration improve waste management and sanitation in both rural and urban areas? Area 3, what community level strategies can sustainably improve environmental health indicators? So, how are we going to form these groups? We shall be counting 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And that one work? Yes? Yes. So, and we have group leaders. Okay, group leaders will come and pick from here. They are group questions. So we are starting from. Are you with us? Mukulu Gisomeria. Hello. We are starting from there. So we are counting 1, 2, 3, 4, 5. Then 1, 2. At the end of it, we shall have 5 groups. People will dissolve into the 5 groups. We are starting. Gisomeria be the lead person there. One. Hello. Let them talk. They will forget. I would love to hear them say it. Because you are not talking, Kisomera, you are not giving them, let them talk. 1. Hello?
Yes, they are part of us. Everyone here, even myself, I will back. Hey, okay, come here, come here. Okay. Group ones come. Group ones stand up. Stand up. The ones Banange, we have said groups. The ones. Can you rise? We want to locate you. Those who are number one, stand up. We are not here for jokes, guys. Eh? Can the ones rise? Okay, the ones, you go behind. Go behind, the ones. Go behind. We are going to do our work within. And let you be allowed to move. You should move. The ones, can we have the group 2 stand up? The twos. But you guys, what is wrong with you? The twos. Twos, you come here. Twos. Look for him. Twos, this side. Twos. Can we have group 3s to rise? The 3s. One of you should come here. Come forward. Group 3, you be there. Where Karambi is. You converge there. Karambi, you are the team leader there. Group 2, group 3, threes, come here. I am not understanding. We are remaining with the 2 groups, but people are still remaining seated. Can we have group 4? The 4s. The 4s. The group 4s, you be here. The fives here. But this is group 2. Okay. I think 5. What's the lot? 5. What is the 5 in the middle? Kirere, come and take the group. The 5. Now the questions I will keep repeating because I have copies here.
I want to guide as you settle in your groups. As you settle in your groups, every group has 3 areas. Every group has 3 areas. You are going to do it this way. For example, group 1, there is a question. How do staffing levels and staff distribution affect staff's delivery outcomes in the Kasese district? You will all handle that and give the answers given to one person in the group. You gather the answers and give to one person. Then you go to question 2. You give to a different person, right? So that we segregate our answers. We should not mix them. We go to question area 3, we do the same. Aro. This is group 3. Which group is that? Which group is that? Group 3, you have had the instruction. I guidance. And we are giving ourselves each question 5 minutes. So 15 minutes. Our timekeeper, and I have a timekeeper now.
What we are going to do,
you are
answer question 1. All these
the DHO is the
for question 1, put them on one paper. Everyone write if my and then you stick there. Yes. Read the question, then you answer it, you discuss it, you discuss. No, you write, everyone write. Then you discuss, then you stick there. My discussion will take us a lot of time. Just write your mind. Yes. Just keep. I'm going to read a question. Question number 1, you give an answer.
Oh, haya somi hiyo.
The question says, now the question says, a topic about accountability.
This person get everyone hand over. Also, we can even question number 2. Kama mwa ito was question number 2. Mwa ba kudukura mwa question number 2. Question number 2. Are we ready? Who has no paper? So the question number 2. So how can accountability be improved across ordering, storage, and dispensing of medicines? How can accountability be improved across ordering, storage, and dispensing? Ordering, storage, and dispensing. Ordering, storing, and dispensing. How can accountability be improved across the ordering, storage, and dispensing? How can accountability be improved across ordering, storage, and dispensing of medicine? Ordering, storage, and dispensing of medicine.
Let's bring our stickers. Let's bring our stickers. Naeka hapo kujistiko na mwa kasaga. Ordering, storage, and dispensing. Pick the third question. Everyone pick the third question. Do we have all of us? So you are here, you write where there is no sticker. Where you write no sticker. Where sticker then. So the third question. Listen to the third question. What role should facility in charges and district managers play in ensuring transparent medicines management? What role should facility in charges and district managers play in ensuring transparent medicines management? So, question number 1 will be presented by Raymond. Question number 2, question number 2, Sister Clark. Question number 4, number 3. Uliwea Kasaku. Wait. Question number 3. Sister Clark. Ronald.
I think our time is almost done.
I think that right? Can we reconvene? Let us reconvene and We shall handle group by group. We shall handle group by group. We can reconvene members. Because I'm observing not every group is ready. Yes? Group 2 is ready. Can we reconvene people of group 2 and group 3? Those with the questions, those with the answers from every group. I want three people to come here. Answer. I guided that we shall have 3 people from each group, not one person to handle a question, all the 3 questions, right? And we have the 3 to come forward. Hello. I am repeating myself. We agreed that in every group we should have 3 people, each question 1 person. And I have the 3 series. We have 6 in front here reserved for you. Hamza, of which group are you? Group 4. So group 2 is ready. 1 person missing. Group 2 is already in front, and we are asked, guys, that you should not move. You are being broadcasted live. Hey, be a bit static. Hey, the movement should be limited. So we are listening from group 2. The mic is there. The microphone is there. We are starting with group 2. Members, this is group 2, and we are going to present it 3 people. Our question reads accountability for medicines and supplies. Then under that we have a question, what system weakness contribute to stockouts and expiries of essential medicines in health facilities? And we have other members. Already we have started presentations. So these are the views from the members. Number 1, push system to facilities from GMS and National Medical Store. Lack of teamwork and transparency between staffs. Number 2, unconditioned ordering and demands of drugs. Members, can we get settled? Let's sit as where, so that we can have in group to present to us very orderly, because we all need these answers. It is not for him alone, but for us all. I first suspend your presentation because get seated. Because these people have to say to hello. And all of us face this side. Let us face this side, members. Let's face this side. And some person should help me tell those who are outside to get in. Those outside, come back to the hall. Kisomeria. Where is Kisomeria Sergeant? Go tell everybody to come in. You are my chief whip. Use the carrot, don't the stick. Tell them to come in. I now let us minimize the movement. Tanyahambiroko yu jama golende kwa yetu. Now you can present. You read the question first, then you give the answer.
So this is group 2. Ending a question under accountability for medicines and supplies. So question 1 reads, what system weaknesses contribute to stock outs and expiries of drugs of essential medicines in health facilities? B of it, how can accountability be improved? Okay, fine, thank you. So, solutions to question 1, the weaknesses. Push system to facilities from national medical store and joint medical store. Then lack of teamwork and transparency between staff. Unconditioned ordering and demand of drugs. System weaknesses contributing to stock out. Poor ordering system. Lack of orders in usage, e.g. fast come, fast use. Poor planning, poor stock management, polypharmacy, then poor, this one is repeating, poor stock management still. Then untimely ordering, delayed deliveries from national medical store, no notification for need of drugs, redistribution in different health facilities. This one again, push system to facilities from national medical store, not consumed at that level. District not regularly collecting excess drugs from facilities. In charges not reporting access supplies. Push system still. Short expired drug supply. Ordering and the quantification of medicine. Poor ordering and quantification of medicines. Insufficient inventory system, lack of awareness of drugs brought by national medical store, poor attitude of store managers while requesting drugs, inadequate supply of drugs and other supplies, inappropriate prescription can also contribute. supplies from national medical stores for treatment of drugs over from health facilities. Poor documentation on stock cards, staff burnout, and limited human resources. Others are repeating themselves. District store people don't allow respond whenever called in case of access stock in facilities. This one is repeating: poor ordering system, lack of ordering usage, first come, first out. Poor planning, polypharmacy. I think others are already them. There's this one. Unregulated ordering, then lack of display of available drugs to prescribers. Others are already them, like this unconditioned ordering and demands. So that is question number one. That is responses from the members of question group 2, question 1. Thanks.
Thank you, brother. Centenary Caroline in Where Health Center 2, handling the second question of the accountability medicines and supplies. How can accountability be improved across ordering, storage, and dispensing of medicines? And these are suggestions from different members of the group. And they are saying there should be proper recording of drugs in all departments. And they are saying use of proper recording stock cards and stock books. The stores, registration and approval system should be done at each point. Then they should provide training to staff about storage and filling of the stock cards and stock books. They are saying there should be proper documentation of registers and balancing of dispensing logs. Then inventory should be taken appropriately. They are saying there should be proper documentation at all points. They are saying in charges should be able to address gaps during facility meetings, implement standards, SOPs, as well as ordering, receiving, storage, and dispensing. Clear responsibility assignment. That's based on ongoing staff mentorship on stock management. And there should be introduction of digital gadgets to monitor stock at facility level. Ordering should be according to number attended to in a quarter, giving a consideration of those medicines mostly used at the facility. Not ordering commodities. Not used commodities should not be supplied and quality storage. Then logbooks for dispensing should strictly be used and balanced. Some points will repeat themselves by ordering only at least twice a week to avoid misuse of blood. Because use of logbook repeating itself. Then need to recruit more staff that will help in proper management of accountability and mentorship in health facilities to help in knowledge gap. Then stewards to use a paper or people first in, first out, or first expired, first out. So, discussing now to have talked about it. Then they are saying we should be able to calculate a monthly stock book. In the other side, for that matter, allow me to raise my question. Thank you.
Good afternoon, members. I'm Asim Ronald, in charge at Kibra Health Center 2. So, from our question, I'm tackling number 3. What roles should facility in charges and district managers play in ensuring transparent medicines management? Here we are talking about the roles of the in charges and the district persons in the ensuring of transparent medicine management. So one of the roles someone had to raise was the availability of facility in charges at the stations at all times. So that the facility in charge is taking charge of what is taking place of all businesses at the facility. Then there is another point, which is on-site CMEs that should be done at the facilities and monitored by the facility in charge and the district people. Use of stock book and other related store registers that are needed to be used should always be encouraged to be put into use at all times. Now, sometimes people use a requisition book and will not use other related issuing order related books. So someone was saying we use all those other books that are needed in store management. Then proper data management, so that when the in-charge is giving reports, should be actually reporting what is on the facility, not from his mind. Conducting monthly or quarterly performance review meetings with your staff at the facility, so that you weigh yourselves on stock management. Then there is calculation of average monthly consumption, and then the access reported to the district and possibly taken to the district stores. Ensuring supervision is done at all times at the facility by the facility in charge. Those are the points that were raised. Thank you.
Yeah, thank you very much, Group 2. And Group 4 was first, so you will come after Group 4. You had the Secretariat
after presenting.
Yes. Yes, good evening, members. Our question concerns data quality and completeness. Question 1 goes, what factors explain gaps in reporting timeliness and completeness among health facilities? Factors that explain the gaps in reporting timeliness and completeness. So these are the gatherings that we captured from the participants. The first one said there is knowledge gap of data personnel on some disease conditions. There is also the system goes down occasionally. Then another point is said some facilities don't have records personnel. Then another one said because of not making summaries may lead to late reporting and incompleteness. Then recruiting incompetent and trained records personnel. Staffing levels being low. The report system 6767 goes down. Another one say attitude, internet data, knowledge gap in records personnel, lack of personnel at some levels. Then another one says knowledge gap, understaffing, poor network. So overwhelmed workload, medical records personnel from different registers leading to delayed reporting. Then another one say knowledge gap, lack of seriousness, lack of cooperation between staffs. Lack of feedback. Then another say challenges on reporting are due to incompetence. It gives you feedback that you have reported when the report has not reached. No attitude, no computer literacy among data personnel, becoming poor network of the system. Others are network problem. I think the rest are repeating. So we can go to question 2.
Question 2 goes, how can data quality and use of routine data be improved at facility and the district levels? So these are the answers. Routine CMEs at facility levels support supervision and education to facilities by the districts, encouragement of teamwork of health workers in facilities, provision of internet bundles by the facility management, then ensuring proper recordings, low staff involvement, use of digital, daily capture of data, then assigning each staff responsibility, review and share data before submission, use of right tools, reviewing and auditing data, motivation and support to data, HMIS management personnel at all levels, trainings and mentorship of staffs, use of digital data system,
data stroke HMIS dissemination at all levels. Ensuring completeness of all patient records and registers. That is number 2. How can data quality and use of routine data be improved at facility and district levels? That was answers to Akana B. Thank you.
Nindo Salome, in charge person. I'm presenting question on accountability measures that encourage better reporting performance. So one of our members said each department should own its own data cleaning, view of reports before submission. Then the other said departmental reports and collection of reports from departments, displaying of funds received and expenditure. Then another member said performing review meetings and cleaning and data cleaning. Then budgeting for data. Then the other member said carrying out performance review meetings. Then departments being accountable for their own data. Accountability can be able to account through meetings, then sharing feedback between district and facility, then making review meetings. Then another member said giving feedback about the different data from various departments. Then awarding good performance data collection. Then support. Then another member said performance review meetings, facility level. Then improve supply of quality data tools. Then improve staff. Other say data quality assessment. Then timely submission of facility. Then internal support supervision.
A hand clap for the team. Thank you very much. One of us has dropped his or her Airtel line. You can check if it is yours, come and pick it from me. As group 5, come forward and present to us. Group 5, if it is not there,
Afternoon, everyone. By question 1 says, why the Latin coverage and hand washing facilities The first answer is lack of awareness about the importance of having coverage and numbers. Number say cultural resistance to behavioral changes.
The volume is still low. Put it near the mic, put it near the mouth.
Poor mindset change.
Poor mindset change.
Poor enforcement. Lack of inspection. Inadequate water supply in some areas.
Let us listen to the presenter, guys.
Almost all the answers are the same.
Next question. Next question.
Thank you very much. Question 2 reads, how can multi-sector collaboration improve waste management and sanitation in both rural and urban areas? These were the answers that were generated by Group 5. This is Mambo Agnes presenting Group 2. I mean Group 5, not Group 2, guys. This is question 2 for Group 5.
5. Okay,
yes.
5.
Yes. Number 1 was a behavioral change and shared responsibility and policy. Then there is poor waste management. Now this one was giving what is happening in this area. Then there was also strong policy enforcement. Then if it is in Kasese, because that's where we are, we say KMC can devolve and at the same time enforce their bylaws that are devolved in a multi-sector way. Then also integration of, there is integration of policies, something like that. Of course, handwriting can also bring issues. Then also multi-sector collaboration promotes awareness of sanitation impact on disease prevention. Then it pulls resources together and this easily raises funds for waste management. Then collaboration pulls ideas together. This isn't solving problems. Then also by putting on waste bins at one collection center. Then there was also ventilation, something like ventilation. Handwriting can also bring issues. Then another few words, mindset change on how our waste can be handled. Then
let us pay attention to the presenter.
Ownership of waste and planning for then better mitigation and prevention strategies can be achieved. then health education can be achieved. Then somebody also wrote, two heads are better than one. When NGOs come, they put impact by donating a lot of things to the community. Then waste management and sanitation in urban areas. Then continuous sensitizing at the community. Then provide vehicles to collect and dispose of waste. Then continue educating people on waste disposal.
Thank you.
Other issues are below here. Public-private partnership, integrating the formal sector, then behavior change and community ownership, then policy and technical support. Members, without wasting time, let me stop.
Thank you.
Secretary
Next.
will do the rest.
Next.
Yes, now.
Next. Thank you so much, my co-presenter. Martin again presenting on question 3, which was what community level strategies can sustainably improve environmental health indicators?
It is group 5.
Yes, group 5, but question 3.
Yes.
Yeah. So, as you know, this is a sector all of us, we can take part in it. So, these are part of your strategies you can make from here. Identifying and training sanitation and hygiene ambassadors, continue the implementation. Then we have number 2, the use of local champions. So after identifying them, we use them in these communities, engage and sustainably improve the sanitation and hygiene. So then local champions should be given and facilitated in these follow-ups and whatnot. Another thing was carrying out home visits. So let us do the home visits at the village level. We talk about the local chairpersons, the councillors, and the LSA assistants. We can do enforcement at the village level. The village council can do that. So youth engagement, which enables us to shift the norms easily from the local norms we had of not having a latrine to having a latrine. Then meetings carried out by the health sector, which involves community leaders for us to enable them understand the challenge being faced in these villages. So those are our points on the how all the community level strategies we can implement, you and me. Thank you so much for listening.
Asante sana. Next is group 3. Group 1 will be the last present. Group 3.
Yeah, my name is Gina Pastesia.
We are here to present the risk in this question. Calculation of data in care. Question 1. What extent are data routine outpatient, maternal, and child health services? As we realized that most of our facilities have started integrating this service, and we realized that we are at least at a level of 35 to 50%. We shall see the barriers that hinders us not reaching 100% from our next presenter. Otherwise, integration has started even in health center tools. They are testing and referring to health center series. So most of the information will be given by the next presenter who is going to handle barriers preventing affecting integration of HIV testing and treatment services. Thank you for listening.
Yes, next.
Everyone,
Evening.
by the name of Australian, I'm tackling question 2 of the 3 questions. The question reads, what barriers prevent effective integration of HIV testing treatment and follow-up in care? The group answered so that maybe they will read the question and the exact one. Answer number 1, there is not great staffing or not great human resource or facilities. And there is also an issue of accessibility, whereby you find that the queue is always long and the people, and there are very many of them, find that when there is need counseling and other things, so find the necessary waiting for those. Another point, we have knowledge gap among health workers. Find that some people are specialists. Whenever the patient comes, they will say, because the other person is the one who has knowledge about gap or the knowledge about us, they will say, the person is there. The other person. So we request that people should be trained about HIV so that the service delivery can be properly given. Another point, we have limited space and infrastructure. In our facilities, or having a little or less consultation room, so we don't give enough counseling and our equipment are not enough. This one also compromises service delivery. So we give the quality of patient care. Another one, we have stockouts of the critical supply. Sometimes we get stockouts of testing, mostly like these facilities, the PNFCs, they will get patients to be tested, but there is no stock in their facility. So you find that they will not be able to capture our patients and add their in those facilities. Another challenge, you have logistic challenges, and the logistic challenges, this one will be the transportation cost. You find that you have a patient to follow up, like in the hard to reach area, like my place in Tondo there. The highest village, like so the transportation and hard to reach will make you not reach there. Another question, another point we have inadequate funding.
Just to give outlines.
key resource for the community is a support staff. Another point, to have high reporting burden. Another point, there is limited district team. Find that the district team will always come for mentorship once in a while, whereby you find that as facility will be requiring their help, but don't have that knowledge. So we request them to always come to us for proper service delivery. Another point, to have stigma and social support issues. People fear disclosure. You're having your HIV, but you don't want your neighbor or your family member to know, or you will die in silence. Thank you so much.
Good evening, everyone. I'm called Rwenzori. What is not I'm here to present the third question, which says, how can integration of HIV...
We are talking about what is making you talk.
How can integration of HIV services improve projects, improve patient outcomes, reduce stigma? So these were some of the answers that we came up with. One, how? In a way that if patients are handled holistically together, it reduces that stigma compared to worked on in an HIV. And another thing, we came up with patient holistic assessment. And they are in an integrated
Let us listen to the presenter, and the presenter be loud, because you are practicing a lot of...
To if it was just worked in an HIV clinic. Another answer is there is discovery of other new illnesses. For instance, if somebody was in an HIV clinic alone, they may not investigate to find out other illnesses. But if it's in a several things have been done, so you find that other illnesses first be diagnosed. Then when it comes to PNFP, it reduces on the costs. This is in a way that if a patient is handled holistically, it reduces on the cost instead of being worked on by, by one clinician and investigates properly. And one person at one. I think that's what you came up with.
A hand clap for them. A better one. Asante sana. You know, Babi was scaring you while she was doing this. That's why the noise was there. Can we have group one? Secretariat. Leave everything to the secretariat. And I will ask the secretariat to be making the frame for the action plan, so that because they are giving us areas of intervention. Group one. Now this is a group of men, only the group, the previous one was a group of what? Of ladies.
Ours was group one, which was talking of human resource. And question one is, how do staffing levels and staff distribution affect service delivery outcomes in the district. One talked of high professional skills. High professional skilled staff are placed in health centers like 2 levels, and this demotivates the staff because it does not provide work there. Then 2, high mortality rates, they increase because patients overweight. Another one talked of long waiting at every point, because patients are very many and the staffs are very few, then they wait for a long time. Then psychological torture to staff and both patients. Then another one was inappropriate location of staffs for duty. You are a midwife, you are doing clerking. Then another one talked of poor data management. Like they were talking of triage, you cannot do all the activities because you are alone. Then poor utilization of policy for placing staffs at appropriate centers, where they talk of 18 at health center 3, you find you are 6. Poor attitude of staffs. He has been there for years, like 10 years, 3 years. He thinks he cannot be changed from there. He has overworked. He's in the mountain. Then planned absenteeism. You are very many. Then you plan to be absent at all the time because staffs are there. Then another one talked about delayed reporting. Because you are very few, the work is too much for you, then you delay to report. Those were the points that were suggested by Group 1 for A of that question.
Good evening, everyone in the house. I'm a medical clinical officer, Biryandi Henry. The question goes, what are the strategies can be adopted to improve staff retention, motivation, and performance, especially in hard-to-reach facilities? The point we looked at, staffing report, we looked at the accommodation. Here on accommodation, the staffing report early on the duty and time. Here we're looking at the staff reporting on duty and early in order to their services.
Put the mic near the mouth.
Number 2, it gives productivity of work, quality work, and it gives morale. You know, when you are sleeping at your own pace of time in the house, you will wake up when you have the whole of the energy. So you will have to wake up when you have the whole strength to run the duty for the whole day. This now in one department, in Mahango, for example, I'm a clinical officer. You'll find that all the duties are looking at me. OPD, sometimes you'll find me in the maternity. Other time you find me everywhere doing a triage. So sincerely, I'm requesting at this point. I'm requesting also you have to look into our understaffing in Mahango so that you can do boost it up with the staff. Roughly we are 8. I'm 1 as a clinical officer. Another point is that this accommodation, it also reduces our economic status and it motivates us also. When you have your own accommodation, it also reduces it helps in the confidentiality. Like for example, you may be having a family and your wife may need to visit you in the working station. Then another one is the periodic transfers. We are requesting that at least every staff who is allocated on a certain facility should be having a calculated time, minimum of years. From this year to the other year, you should work and you go to another session. So it will also improve our performance. And it will also help to gain more skills and experience and to be exposed to the most uncommon conditions within other big health facilities. We have also another point of hard to reach allowances. We are requesting that allowances should be implemented by our high-ranking officers. They should look into it because this one will also motivate us to work and improve our performance, and it also earns. It will earn us also the life of living, at least to reach a certain high level of standard in our working system. I thank you all. God bless you.
Next.
Yes, good evening, members. My name is Dr. Kure Moses, working at Nyamira Mehere Center 4. Question part 3 of our activity was, how can accountability mechanisms be strengthened to ensure health workers adhere to professional and ethical standards?
Professional and ethical standards.
We suggested that there should be reward and sanction of staff. Reward and sanction of staff should be strengthened. Those ones who are performing very well, we reward them. Those ones who are performing poorly, we call them and find out the problem so that we do appropriate actions.
We sanction them, yes.
Then the second point was periodic assessment and feedback. You find out that some of the staff members are being assessed but are not given feedback. You ask yourself, why am I not promoted? Am I not performing? Yet you are always filling appraisal forms. So that one should be strengthened. Then another one was continuous training. These staff members should be sensitized about what they can do in order to perform, and given refresher courses if needed or CPD, and encouraged to attend various sessions that are being held within the district. For example, MPDSR meetings. Then there should be support supervision, which should be strengthened at different levels. Could be HSD or at a district level, depending on the health facility. Thank you for listening.
Asante sana. Niongeza tena. We have had the presentations, and you handed the secretariat all your notes. And what I wanted to say, there may be some few additions, and I am welcoming the supplements from like 2 to 3 people. What is it next, Doctor? Okay, fine. Doctor, you are welcome. As the doctor is looking for the document, you may be having some addition. Yes? Anyone? Yes, come forward. Sophia.
Thank you, sir. Thank you, Chair of the session. Once again, Ngola Person of Pruvia in charge Nyakawangala Center 2 in the position of medical clinical officer. As an addition, right away from number 3, our team, it was to improve for the improvement of the outcome of HIV services, integrated routine services. So we left one, I thought of it when my colleagues were presenting, like having routine counseling. Because at times they come when they are fearing, they come when they have own thinking. At times HIV clients, they come to us knowing that we're going to reveal their what? The information. So what's continue telling them the burden of their disease as well as comforting them, this will let them improve their well-being with their conditions. Another thing was to improve on the outcome of integration of HIV services was health worker to patient relationship. If we make it if we become too friendly to them, this also will increase the outcome of their well-being. So another point was on the stockouts. The stockouts, in addition to what was talked, like record keeping and whatever, I realized the one that our colleagues had left, there is a rational use of drugs and supplies. At times somebody comes, I have to go. We don't probe. Instead taking is a bit halfway. I have to go start from there. Amoxicillin. Not knowing is it viral at that point or is it bacterial? Then find out already stock out amoxicillin and whatever and other drugs. So this we need holistic approach of a patient in order to discover what is biting the patient. If we make it halfway, automatically we'll end up giving the drugs with a condition which is not intended to the drug and keep on crying for drug stockouts. Then another is inadequate. There's an imbalance of drugs. During ordering, we feel as if we have ordered. But when drugs come, find that the number of doses of drugs that has come is not matching with the patient's ratio. You would treat, they give, for instance, when I was in Ebugoye, there's one time they gave us doses of artesunate, 170 doses. And at the end of the month, we were treating around 300 cases of malaria. So I see where the logic is. So at the end of the day, 1 month, either 1 month or 2 weeks, remember artesunate is around 3 doses. Even if you take one dose starters, you add on oral, still they are still less. And then 1 month, no drugs from the community to them to us. At some point, you take the stock out at that level, but the problem is not ours as health workers. Then network recording at some point, we talked about it. For this one, at times, from practice, at times you can pack your drugs, I'll take them at home. You fail to record. So assume we're around 8 staff at duty, we don't record. Then do you think these are not to be accounted for? So the following day or 3 days, again we order for another one. When these ones are not being reflected in our records. So this one should emphasize on those record taking so that to track the way drugs are being out of our stocks. By this, these are the few observed. Thank you.
Dr. Teko. Okay, thank you. I saw it wise that these are just few slides, don't take the slide, and it's for our own good, for those ones who are being followed. Was at the about reps set out seven monitoring unit. We heard about it. So now some of what we have discussed, if you implement them, you will survive that. That is for your assurance. Because now if you are able to account for medicine, you are safe. Now for midwives, when that team comes, they also has interest in my market. There is a midwife who was almost arrested because they thought to account for. But she was pregnant and somehow she was holding out to account by she was given by morning to account for my market. So every commodity account. But now there's what we call comprehensive service standards manual 2021. I've just extracted out some the number of you are from facilities. If you follow some of these standards, you address a number of things in a systematic way. And that is the book was that 2021 comprehensive F-service standards manual. That's Dr. Amon, if it to ensure I will share. And now it looks about stronger governance. And this one along with management and leadership. Now I usually tell people to embrace leadership and also with minimal part of management. Because leadership is about creating followers. If you're in charge and don't have followers, you are finished. Because whatever you bring up, you will be fault. There's what we call meeting after meeting. You have a meeting, after the meeting, there's a meeting. Now that one, if you ever see that you have a meeting and there's another meeting, you are not safe, okay? How to manage that? Now the issue of transparency, one of the things it is transparency on PHC funds. Sometimes people replace the fee with personal health funds. Yeah? Personalized instead of primary care, personal health care. So there are some charges where when the PHC comes, the money disappears. Now what is not they want to put so that is the issue which undermines effective and transparency. Social accountability. We are supposed to engage with the communities and also issues of information gap. But another thing which we need to look at the data and the use of data. As regional referral, we are supporting districts now. We have bought a new approach of supporting districts. We have strategic outreaches, interpreted, and we have everything. Most of it is managed. Radio talk shows, some of have implemented these activities, and now we are adding PDM. We are going to react pillar number 4 of PDM functionalized. So now what is the first entry to managing facilities these committees? Now each human resource case to the district before this committee handles. By procedure, if you look at the rewards and sanctions framework, because there's a procedure, institutional what at each level. So we expect this committee now, which has been submitting action points to DHO's office from UMIC. Submitting the now the standard says that you are supposed to send those reports to the DHO, and there should be a file of UMIC at the DHO's office to follow up your action. So that when they are doing support supervision, also they assist. Because some of those actions are for the district. So that is one of the things. Now we are supposed to, and also the data is supposed to link up with the community. So if you have a meeting and you are not connected with the community, they are talking about something else. You are not having an effective meeting. Now these UMICs, they can tell you, I've used them, they can tell you where people who are stealing it drugs. People know them in the community. You know, this is accountability. They first engage the community, they have a lot of information. For me, when somebody told me that I'm going to call you when this person is taking drugs in the box. And I had to there's another information which came and they had to do a night operation. Okay? And because of the community. Now, we have to improve this one. But now your worker plans, the issues of work strategic plans, you are supposed to embrace the guidance of Ministry of Health. Now, each facility is supposed to budget for the outbreak. Each facility is supposed to budget for outbreak management. What's the budget? Each facility is supposed to budget for we are supposed to budget for balance. Now, as you are supposed to guide them into making strategic information. Now, there is issue of financial reports. These are part of accountability. Now, for us, we are now account for medicines. There is a form which you have come up with. We will have to account where medicines are going. Now, the procurement plan, which facility has a procurement plan and is approved? Okay? So every facility, this one says every facility is supposed to have a procurement plan which is approved, not just the performance worker plan alone. Now you go to the last one. Of the first one, there is something to do with practicing licenses. Do you know that if you don't have a practicing license, you are not supposed to be, you are supposed to be kicked out of service? And even if you are in government, the moment your license expires, you cease to be needed by government. So that is, this one says all that. But the last one is the workforce right qualification. If you are doing something and you are not mind to do, if anything happens, you are in for it. And also by law, your supervisor also can go in for it because they have neglected the supervisory role. The clinical governance and quality improvement systems. Now the issues of 133, as a leadership, you share the direction. You need to sit with your staff and share where are we going. Okay, we have medicines and you have to stock out. These points we have brought. Where do we need us? Where do we see ourselves? In the individual, we never used to have overstock of medicine, but you start one day, and I'm telling you, if you need the quantum, don't if you have a stock out of quantum. Please, you tell the come on, we have more than enough. We have more than enough testing kits for HIV, more than enough testing kits for malaria, more than enough medicines for amoxicillin, and we have closed those lines. So we have to have a direction. Where do we not go? If we want to have medicine. When you are ordering, you have talked about ordering. There's what we call the vital essential. And now, if you are not supposed to order less than 80% of the vital, because those vitals are life-saving. So when you in your work procurement plan for medicine, what is the percentage of the vital in your financial management? What is in the financial procurement, pharmaceutical finance management? What's the 80? If you are below 80, it means you are risking losing the mother. Because most of these vital medicines are under MS, maternal and child care. So you risk, now you find that the facility has ordered for more Panadol than anything. Panadol is cheap. You concentrate on medicines which cannot easily be gotten back. Now the evaluating reports, this one and reviewing the feedback. I saw on your thing we had the unsubstantial survey. We are supposed to review at the facility level and we address them. Okay? So that is one of the things which we can help us to. The signage, you need to look for direction. If your facilities, somebody is not even asking that way is one, everything will be a sort of local language. Now, it is this information disease burden. Now, most of the times you talk about stockouts because your ordering is not matching the disease burden. You order outside there, you need to address. And so now we have moved away from just ordering to using the disease burden. And now the last one, the monthly departmental or facility meetings and the action points documented. That's where the problem, people sit but there's nothing which moves on. Now you need to sit and identify problems. This is whatever you have discussed, these are challenges over the facility, and especially that. However, going to a facility, I counted the delivers and was less by one. And now I was wondering, how can somebody fail to count 30 delivered? And you report 29. Yeah, and yet you one of the requirements. Okay, that's what I wanted to talk. We need to take things, key things to note under this 5 years. We are coming to 5 years. Don't lose any company. We are working with one of your partners. We are going to train your members of access. We are going to establish and give. We are using these different processes. Now, after this, project is package, I should ensure that when I get a Say all this for God and my country.
Asante sana. Yongeza tena. Some backbenchers are not giving morale. Sorry for that. Thank you, Doctor, very much. In fact, you have given a summary of all that we have been discussing in this group work. Importantly, today we know we have ecumenical prayers at the district per month, and today the Anglican led the prayers. Next month, the Adventists will lead the prayers. The month of April, the Catholics and the Bishop himself of Kasese Diocese will be there. You know, we are hosting the Namugongo in June, so he will be there. But I extended the apologies of the Department of Health because of this important meeting or function. And I wanted to bring out two things that came up to share with you so that you don't lose out completely. Issue number one, I don't know how he formed his thing. Hey, you have some presentation? Need table. 2 slides. Should I make my presentation now? Okay, you first present. I will finish. But you be first. There is a mic there on your table.
Okay, this is our final presentation. We have gone through a lot, and we have seen our performance, but we have selected a few indicators to gauge ourselves, and also to gauge ourselves without considering the level of the health facility, without looking at what target population you are supposed to see, but we are looking at operational indicators. One, we are looking at screened for TB at OPD. So we are just getting the number you screened versus those who came. Okay? We look at under 5 screened for malnutrition. Those you assessed versus those who came. We look at vitamin A second dose. Now, for immunization, I try to look back, and you will agree with me. If you are to get second dose for vitamin A, you should have received the first dose 6 months before. So we are doing Child Health Days in April and October. So I've pulled out the data for first dose for April and then compare it with the second dose in October. Okay? The same for deworming. When it comes to pregnant mothers tested for HIV at ANC1, those who are tested, those who came for ANC1. Those who received mosquito nets at ANC1, those who received versus ANC1 attendances. Then DPT3 coverage, I am using a denominator determinant where I am also looking at if you receive DPT1 in October, you are supposed to receive DPT3 in December. True or false? That's true. Then I've also pulled out the timeliness for weekly surveillance reporting. Okay? And also submission of HMIS 105, because those are the data that we use for his meeting. So overall, I have ranked all the facilities, and I'm going to share with you immediately I finish this on a WhatsApp group so that you see where your facility is. However, what I will see, even when we are not looking at populations, but you would find facilities that are shooting up to 1,000%. So how do you get DPT1 10, then you go DPT3 get 400? Those are the scenarios that we are seeing. So as a penalty, if you are above 100%, instead of getting the 10 scores, all of them, we give you half for not doing proper planning, especially in EPI. Why are you getting more than what you started with? Okay? And for other services like screening, why should you screen more than those who came to your facility? It means you're not reviewing your reports. But to bring you up to attention, we are giving you a penalty by giving you half of the scores. Okay? So from what we have so far seen, we are seeing the ones at the bottom. Those are the facilities that are not performing well. Yakirema, Rusese, Bumbeka, Patiro, Mwea, Himastars, St. Thomas, Bethel, Muvuku, Yakatonze, Good Care, Karingwe, Bukok prisons. You can see those are facilities that are not performing well. Okay? I just picked a few. But also we have facilities that are making us shy. Mount St. Mary Mosque. And even last time when we tried to use the populations to generate our league table, again Mount St. Mary's was performing very well. It was among the best performing hospitals. I think this facility, what we have seen as a challenge is maintaining your position on league table. Today you become number one, the next time. Yeah. We thank Mount St. Mary's for maintaining the position. Then the second is Mahango, Karusandara, Katadova, Charumba, Chanya, Kahocha, as you can see. So our best performing facilities, we have Mount St. Mary's, Mahango, and Karusandara. I don't know how DHO is going to recognize them for their best performance. Okay, so we also pulled out our worst performing facilities that we need to pay attention to next quarter. So we shall award certificates at the end of the financial year as we did last financial year. Thank you so much, Carl. That's what I wanted to offer.
A hand clap for that. But that is very, very important. Which clap is that? That is Dr. Hammond. Okay, thank you. Now we are going to do the closing ceremony. I have looked at the program. You are taking lead. Number one, make your closing remarks. The mic is in front of you.
But I want to thank you for coming indeed, because we are delighted. We are delighted that we've been able to sit here since yesterday morning up to this late hour, almost 6 o'clock. We can't take that for granted. Now, importantly for me, we called you as managers, and we've been looking through our performances. All you've seen, like I commented, many of our performances are not doing very well. It all starts with, you understand? Yeah, that one made it very well. It all starts with myself. You refer to yourself. So we didn't call you here to waste time. We don't want to keep doing that. When you look at our trends here, we seem to be regressing. Our performance was not increasing. The trends were going down, and we have to ask ourselves. Beira was here with us, and he was the most unhappy man. He said, what has happened? Now, some funds have been advanced to accounts. Please go and utilize them, and we improve in those indicators. We have seen that most of, you see, you have the answers. When you made the analysis, you have all the answers amongst yourselves. But you as in charges, it should start with yourself, and we should improve. I shouldn't make a lot of, the other day on human resource, we've spoken absenteeism, abscondment, and you were holding those voices in your facilities, you are keeping quiet on them. Yesterday, but one I was making a statement before IGG on a staff called Dayambe Felix. I think some of you should have known him. I make a statement on someone I didn't know, he has absconded. You know the good news that happened when they came and asked me, what have you done about this guy who absconded? I showed them, I had stepped on a salary. That was one thing. They gave a trick. What next did you do after that? I said I submitted to reward transactions. They gave a trick. What next? They went to accounts and found they had deleted him. You understand? So please, when those things happen in your facilities, you report. When we don't, they come and carry us because we have not become responsible. We are continuing to pay salary to some of those guys. They are on our payroll. They have absconded. Anything. So please become responsible. You're there to manage for rust. Come to this point. You are our in charges. Get this point very clear. When you are our in charges, you are not an in charge is just an assignment. You understand? Through this season that we finished, we have about in charges. And we are now demoting based on performances. Please, we are requesting. Don't allow to be demoted because you did not perform. Get me clear. We have demoted 3 because they refused to perform. Even when we call them to our areas and say, why don't we improve here? Nothing changes. We demoted some of them, at least 3. Now, surprisingly, they come back lingering around and asking, please, please, please. An assignment of an in-charge is not a position. So when we say, please go and work in another facility you didn't manage, don't waste our time coming to us again lingering that you are requesting to be reinstated. You understand? You've not done what we need. First go and do something else somewhere else. And allow us to put the people we think will. If they also don't perform, we shall also remove them. So don't go around him, telling him, please, those who will not work with us, please let us perform. We have no problem with you. We are grateful. You are doing very great, most of you. But let us step up and ensure that our performance can put us up. I want to thank you once again. Thank you for coming. I know the rest of the details will be shared, maybe on our platforms. All that we discussed, the minutes, rather the action points will come to you and you read. When they come, internalize them and let us work according to the action points we've generated. Thank you so much.
Asante sana. Now I'm giving the remarks of the cow. Thank you, Doctor. I am starting with what came up in the prayers. 2 things. 1, everyone applied for the job he or she is doing and accepted that will serve according to the conditions, right? Those are not my words, but the words of the Dr. Canon Benson Baguma. Therefore, you are at a call to serve, and you have God's favor if you do well. Right? Let us use, point number 2, let us use our offices responsibly and let us be innovative. Let the good things we are doing speak for us. The good things we are doing as we carry out our job description roles, let them speak for us. Action speaks louder than as cow now. We have had challenges of accountabilities. I told DHO in a DHT meeting, we are not going to release PHC funds to you people if you have not accounted. Starting with the 4th quarter, because I wanted to hold on you with this 3rd quarter. They said it is already gone. I said, yeah. Because people are staying with the whole year without accounting. So, starting the 1st quarter, if you have not accounted for the previous releases, no more release like salary, they have told about it. Number 2, I had brought it, I had noted this, but DHO has talked about it. None of you applied it to be an in charge of a unit. Right? When you were applying it to serve as a health work in the Garissa district, did you apply it to be an in charge? So your hard work and capabilities you are showing is you are given an additional assignment. And the powers are with us as a department to withdraw work for those positions, right? Anytime you are candidates of being redeployed and you are not to serve in those units, let us be compliant with the deadlines, with the requirements. We shall be number 1 in the district. You are doing well. And the region, we are thankful that you have really come to us. Let us take the support supervision from the region serious. This was not there before. It is a new development and we appreciate it. We are not taking it for granted. Please, let us not take the region support supervision role for granted. Finally, let us be innovative in our work. Hapana. Innovation. Asante, with those words, the RDC is supposed to handshake and recognize those best performers. He will come and, at the right time. So, but I'm inviting the chairman 5 to close this gathering.
Thank you. I hope everybody can see me. He has an announcement, 1 or 2 announcements.
Thank you, the Vice Chairperson. Once again, I'm Dr. Tuwenda. I serve with Kaganda as a medical director. It is important to know that we all call to serve and we give service. The announcement I'm making is that many times when we don't know where to refer, especially for certain conditions. I want to make this clear that Kaganda has now a very good and active ICU, intensive care unit, with ventilators. People who are failing to breathe for themselves. If you have such a patient, we can maintain such a person's life and then maybe, God willing, give back life and goes home. Secondly, we have been referring our patients who need cardiac echogram or echocardiography services to Mbarara. Kaganda again has positioned itself to do that service at a very minimal cost and a nearby place. So please, we are trying to position ourselves to receive all other referrals that are beyond our ordinary medical capacities. Please try Kagando. You will not regret doing it. I thank you.
Medical Director, Kagando Hospital. Wambale Mande Girvazio is my name. I have been with you since 2022. I have been Secretary of Social Services I have stayed with you. I'm going to stay with you until May, around May 20th, when we are exiting and another team is coming in. And I want to take this special opportunity, first of all, to thank the Department of Health for organizing this function. Can we give them a clap? Thank you. Two, I want to welcome the team from the regional referral. Doctor and team, thank you for being with us, and thank you for joining us. And we want to continue thanking your team for the support supervision. Please enhance it and enhance it and enhance it so that we can reduce the gaps. In a special way, I want, on behalf of the district, to thank the partners who are present for the 2 days and those that did not come but have been giving us the resources for Kasese to perform. Thank you, thank you, thank you so much. Give them another applause or clap, because they complement our meager budget as a district. Then they make us score. In the morning we were told that we scored 86% in the health sector during the national evaluation. And the other year, health sector did as well. And information which you already know, the people of Kasese, that because we performed very well last financial year, we were number 10. And that accrued 950 million shillings into our current budget. Clap again for that performance. So what does it mean? When we own the performance and then the assessment comes, it is an income generating. One time I even whispered to the former cow that cow, heads of departments who supervise, who toil in the mountains, on the lowlands, day and night, why can't we go and benchmark from the districts that win us so that we can leave position number 10 and get a one-digit position? I know the new cow is going to implement when I whisper to him. So thank you, Health Department, amidst the challenges, the terrain. I want to appreciate you people. The terrain, some of you climb every morning and every evening, is not palatable. Imagine going to Chiraro, going to Mahango, Kasangali, Ihandiro, Buhatiro, even Kasenyi. There are those hard to live and hard to reach places. You move to Ibimbo. My sister was talking about Chondo, Karibu. There are many, and you toil. Thank you very much. We appreciate you as district council and as your political leaders and friends, because, you know, we are scoring in the same goal. When you see a councillor coming to your facility, he's coming to support, guidance. Don't chase him away. He wants to come and appreciate, so that when he comes to council, he can deliberate and forge a way forward that is very practical. So we appreciate the way you work in those hard conditions, and then you can become number 10 overall in the country. Then you are wonderful people. Like we have said, Kasese team is a very strong team. So from the referral, from our regional referral, we have a very strong team. You can even see the content. I have sat, I normally sit in these reviews. I don't miss them. Since I became Secretary of Social Services, I ensure every performance review under health I attend. Yesterday I sneaked out. There was another meeting I was going to attend, but I have sat the whole day so that I can really get the matter. You are doing well despite a few challenges here and there, and good enough to have suggested the way forward. One of the way forward is you in charges to take this combination, PCME, not physics, chemistry, mathematics, and entrepreneurship, but one of the strategies under my PCME is planning, pre-effective planning. You know what goes with planning. The C, the coaching, which involves refreshment, new methodologies of treatment, updating oneself, the knowledge gap. The group was talking about knowledge gap, closing that knowledge gap. You will have made my combination C. Not the chemistry, but C. Then the M, the mentorship, the measurement of performance, the mindset. As an in charge, if you did that M, not that mathematics in quotes, you will be there. Then E, is it being everywhere? Yes, someone was saying, should I be everywhere? It's true. As an in charge, you must be in every department and evaluate what every department does. If you did that combination for me at your facility, you will score and score and score. Availability. I am one of the people interested in management issues and administration. My professor told me that availability at a station is accountability. Availability is an accountability aspect. When you are available at your duty station, that is already mark number 1 or 2 or 3 for accountability. Definitely when you are not around, 2, 3, 4 days, things go berserk. So duty, being on duty is what my professor was emphasizing. Then there is another J which goes as I wind up. If you go alone on a journey, you reach quickly. And it is true. You try it, go alone, you reach very fast. But when you go as a team, together you reach far. It is true. I have seen the pilgrims who go to Namgongo. When they are about to reach Namgongo, like we shall be animating the day, Assess Diocese, it is our day for animation on 3rd June, and we shall move on foot. But when we are at Busega, we get more energized because we are reaching the destination. You can even tell the Namugongo pilgrims that now we have shifted the day, it is in Nairobi. They will walk another 1 week and they will reach Nairobi. What am I saying? When you work as a team, you reach far. Then, Kagando, thank you very much. Kagando is going, I happen to be on the board of Karutech by the virtue of my position. And we have told Kagando to spearhead mental health and make it a niche, so that at the end of the day, since it is even a sub-district, health sub-district, we can now keep getting more knowledge. After all, there is a Kagando University College. Uganda Christian University has opened a college there, and there is intake in August. Please upgrade ourselves. Let us upgrade ourselves. We get more knowledge, and at the end of the day, it will shape our performance. Lastly, Wanakao, I want you to hear this. There is a vice that when I'm a doctor in Rukoki Hospital, I will work Monday and Tuesday. Wednesday, I am in St. Mary's. Thursday, I am in Katadora, private. The other day, I am in KK clinic. So Wednesday, Thursday, Friday, I am not seen. I am seen at Rukochi Hospital Monday and Tuesday. Then again, Monday and Tuesday, 4 weeks, 8 days. I'm given my pay of, your pay. You have done 8 days. There is there is a facility, a hospital I went to, and they told me that, Honorable, at this facility, doctors don't sign the attendance. And therefore, a doctor comes, does the clerking, does the prescription, tells people what to do, and he goes away. I don't know whether the practice, that is a new phenomenon in the practice. You are the professional people. It's food for thought. I thought a doctor should be a role model. When you come as a doctor, you sign the attendance so that the rest of the cadres learn from you. How can we investigate from the private hospitals? I know this is not sounding well in your ears. Can we go to the private hospitals and we say, Dr. Wambale Mande was in St. Mary's on Wednesday, and then Kasese Hospital on Thursday, and then KK Clinic was there on Friday. Okay, of course there they pay you. So that for us we pay you only the 8 days you have been at our facility. I know it has already happened in Buhinga referral. Doctor, you will bear me witness when Dr. Diana came there, when there was a case and it was thoroughly investigated. There are some health workers who have been told to refund the money they were earning from the government facility. Let me ask some general question. What I'm saying or what I'm hearing, is it true or is it a lie? I know the answer may be no or may be yes. But that's what we are hearing, and we are about to swing into action as political leaders, so that we pay you Banakao for the 8 days you have been at our facility. And I think that's why some of the presenters were talking about it. It is a very bad advice. We don't want to hear it. We don't want to victimize you, because we are scoring in the same goal. Be available, do your duty roster, and do whatever. When you have an off, it has no problem. If it is an off, that one we know it is an off. But when you are at a facility only 2 days, and the rest of the time, they are calling you, doctor, where are you? Doctor, where are you? The patient is here, 2, 3 hours, 4 hours, the patient is dead. And when you come, you are only doing postmortem and the patient has already gone. One time it happened at night, a woman was coming to deliver, and the doctor was around, but someone flew and says he wasn't around, and the lady was referred to town. And there are 2 officers who are supposed to do it. Both were absent. So they organized absenteeism is a big vice for an account. Let us fight it, so that at the end of the day, we become victors in our performance. Having said that, I want to thank you once again. And I want to say, if we work together in a team, we shall reach far. Let us be available. Let us do my combination, PCME, and at the end of the day, performance will improve. And mental health should remain our priority as a district. There are so many cases of suicide going on in Bukonzo East. That's why we thought Kagando Hospital, Bukonzo East, as a sub-district, should venture and pioneer seriously into that. When we sat the last board, there is a strategy we decided. And therefore, the rest of us, I'm not saying you leave it to Kagando Hospital, but the rest of us, let us swing into action. Having said this, I want to take this singular honor to close this 2-day performance review for Kasese, and the best is in front for us, for God and my country.
Bama berechenga neryokuwa atya. Tukaita omusabe. Na administrative announcement, Dr. Tabu wako beberia bifana. Ukasa? Can you know?
Announcement, my prayer. So the prayer will teach announcements. There's someone behind there at the table. Someone at the table behind there handling issues of some small transport fund only to health facility in charges who don't get PHC. We expect that these other ones who got PHC, their command is still in the pocket a bit. Sorry to mention that. But because the budget was constrained, those in charges of facilities who don't get PHC, please pass there and get. If someone with bilingual is here, he qualifies. Number two, those of private health facilities also can pass by and sign for a small transport of the media and district leaders. Teachings, please bear with the other interview. And then tomorrow we have a meeting. All private practitioners, health center 3s in town and center 4s in town. Please, we have a short meeting at the district headquarters tomorrow in the morning from 8:30 to 11, 2 hours. We can pray. Lord, thank you for this opportunity. We are grateful that you brought us here safely and we are ending safely. We request that as we travel back home, we enjoy your journey, mercies, and we reach safely again. We trust that whatever we discussed will be put into use and we can see Kasese shining in terms of performance as a district. We thank you for this. In Jesus' name we pray. Of course, my DHT members, as we said, members here were great. Please just around here. Now. 5 minutes.